All right, so the last time I think we wanted to start with this one, but because of time factor, so we will pick it up from here. Okay. Now, like I said before, we are going to end the critical care concepts lecture today so that we can concentrate on some other things later. Okay. So if you have any question, kindly put up your hand and you'll be asked to unmute so that you talk to us. All right. Now, we talked about lots of things. We talked about lots of things, including ventilator settings, what we mean by high or low peak pressures, and all of that. So today we're going to look at high or low pressure mechanical ventilator alarms and how to troubleshoot them. Okay, remember, like we started how we used to do things before. We are looking at some key areas and how to deal with them. Should we get questions around them on the NCLEX, or even in real life situations, how we can deal with situations like that. So over here, let's say you have a patient who is on a mechanical ventilator, okay, receiving mechanical ventilatory support, and you find out that the ventilator alarm is beeping, and you have a display on the monitor. I mean, what I mean by the monitor is on the ventilator, okay? You have something like high peak pressure, something like that, okay? Or you have something like low peak pressure. What does this means? Or any of what we are talking about? What do they mean? So that is what we're going to talk about here, okay? So let's look at our change airway, which can be either endotracheal or tracheostomy tube, and or a problem with the ventilator. Peak airway pressure is the amount of, okay, so before we even talk about the second point here, what we are saying is that whenever a mechanical ventilator blows an alarm, okay, or gives you an alarm, and you know, whatever alarm that the ventilator will give you, there will be a writing on the screen. So if, let's say, the ventilator is sensing a very high peak pressure, it will tell you high maybe pressure or high peak pressure over there. For every alarm, in relation to every, I mean, a particular setting, okay, being tidal volume, I'm giving an example, being tidal volume, being, let's say, minute ventilation and all of that, we have alarm limits that we set. So let's say if for an adult, we've set an alarm limit, okay, for, let's say, I'm just giving a raw value. We've set an alarm limit, let's say the high value to be, let's say, 4, okay, let me use maybe 700 or 600. We've set an alarm limit of 600. Let me use 600 for tidal volumes. Then with the lower limit, we've set an alarm limit of, let's say, 200. Just raw values. Whenever there is any situation or something happens to the patient or whether the monitor or wherever the problem is coming from, And at a point in time, you have a tidal volume, which is either above 600 or below the 200, the ventilator will beep an alarm. Okay, it will sound an alarm. And the indicator or wherever the problem might be coming from will be indicated on the screen of the ventilator, so that you can go and assess and troubleshoot. But remember, like we said before, whenever there's an issue and you want to deal with it, you make sure that you deal with the patient first. You monitor and take care of the patient first before you look at whichever thing that is causing the problem on the ventilator. Okay. So between machines and humans, you choose humans. You intervene, especially if the patient, whether the patient is doing well or not, your first assessment and the focus should be on the patient before you can later look at the issue causing the machine to give you that alarm. Okay. And we are saying we have high and low pressure alarm limits. So like I was giving the example with the tidal volume limits, okay, or something like that. We set alarm limits so that whenever they exceed, let me give you maybe a clear example with cardiac monitors. When you set, let's say, a limit of, let me use heart rate as an example for an adult. When you set a higher limit of 120, or let's say 120, and you set a lower limit of 55, what it means is that as long as patient is giving you heart rate within the ranges of 55 and 120 in between, the monitor will not sound any alarm. You'll be okay. But as soon as patient heart rate goes beyond 120, the monitor will be beeping to tell you that there's an issue for you to check. Okay, and whenever the monitor is also beeping, let's say whenever there is a low heart rate recorded, in such case, you have the monitor also beeping so that you can look at what is happening. You can just imagine if it's a lower heart rate, you know what bradycardia can eventually cause, right? So these alarms are there for you to intervene, though we expect to monitor our patients throughout, but these alarms help to pay rapt attention to situations that could maybe escape us. All right. So it's the same for, I'm explaining this one in different, I'm trying to relate this thing with different things because not all of us are used to, mechanical ventilator. But for the sake of the exams, you have to understand what at least we are talking about. Okay, you can at least try and assume something with the limits or with the examples I'm giving all around. All right. So just put it in mind that you can get high peak pressures, you can get low peak pressures. Okay, whether a patient has an artificial airway, and the common artificial airways we have are the endotracheal tube. Anyone who has been to the theater before, even in the ERs and ICUs, most of us, we know endotracheal tube. And with the tracheostomy ones too, I think it's not too uncommon. Okay, it's not too uncommon. It's not something to, scarce for you to find. So that those two things, because they are not our natural routes by which we breathe, so they become our artificial airway. So whenever there is any alarm, especially peak alarms beeping, it could be maybe a problem that maybe might be pertaining to the client's main condition, or maybe an artificial airway problem that the patient is currently having. And over here, we are saying peak airway pressure is the amount of pressure required to deliver a tidal volume. A tidal volume is an amount of air that you are respiring or you are taking in at a point in time. Okay. With the ventilator settings, because we are controlling everything, you're breathing for you, we set, we have a particular setting that you set the amount of air you want patient to be taking in at a point in time. So what it means is that, let me give an example. Let's say if I am doing maybe volume assist control, okay, like VAC mode. It means I'm controlling everything. I mean every breathing that the patient is having at a particular time. If I set a volume of, let's say, 450 mils, it means I have given the system an instruction to be pushing 450 mils of air into the patient's lungs at a point in time. That's what it means. With a tidal volume on the ventilator, you can set it depending on the settings. We have other settings that you can allow patients to do his or her own breathing. But at a point in time, if let's say patient is not doing well or doing below standard, then the system or the mechanical ventilator can support a bit. So we have different modes, okay? But when you talk about these tidal volumes, that's what I want you to understand. An amount of set volume of air that the patient is taking in at a point in time. So when we talk about peak airway pressure, it is the amount of pressure required to deliver this tidal volume we are talking about. Okay, peak airway pressure. It is the kind of pressure that you need or that is needed for the machine to push in that amount of air that the patient should breathe at a point in time. So at a point in time, if the pressure is becoming high, then it means something is occluding it. Okay, it means something is occluding the airway or the circuit. So it can be either, we look at things that can give us high pressure alarms, okay, or high peak airway pressure. When you hear of high pressure alarms or high airway peak pressure, they are similar things we are talking about here. So you can just imagine if you want to blow air through a straw and you have another thing including the straw at somewhere midpoint or at the end, whichever air that you're pushing through the straw will never be delivered at the end of it. That is how it looks like, okay? So it could be due to maybe someone who has intentionally obstructed the straw, or there's something which has occluded the straw pathway so that air cannot be delivered through. So any condition that increases the peak airway pressure can trigger the ventilator high pressure limit alarm. Okay. So with the continuation, you are saying when this alarm sounds, the nurse should assess for conditions that increase airway resistance and or decrease lung compliance, such as. So we are looking at those things that can give us high pressure alarms, okay, or high peak airway pressure. So the first one can be excessive secretions. When a patient has excessive secretions within his or her endotracheal tube or tracheostomy tube, this obstructs the airway and increase the resistance by which air has to be forced into the lungs, okay? So that makes the airway pressure to be higher. And another thing too is when patients tend to bite the endotracheal tube, especially people with endotracheal tube, okay? When patient tends to bite on the tube, it's a form of obstruction that makes airway flow obstructed. And also when you have a kinked ventilator tubing, okay, when you have, the last time I showed you a circuit, how it looks like. Okay. So at a point in time when you have any, whether the endotracheal tube kinked or the circuit, the ventilator circuit, when you have any part kinked, you can have this airway pressure high alarms. Okay. All right. Then we also have conditions that can also give us a low airway pressure alarms. Okay. I mean, low airway pressure alarms. So some of these things are when you have a tube disconnection. You know, this is how I want you to think about these high pressure alarms and low pressure alarms. When it comes to high pressure alarms, think about anything that increases the resistance or the pressure within the tube. So being kinking, biting, secretions obstructing the airway, and all of that. Okay.
I use something to cover it.
Thinking about the next one, which is the airway, I mean low pressure alarms. Things that can give us low pressure alarms are situations where you tend to have air leaks. Okay, the air that is being delivered to patients, you don't have all of them reaching the patient. You have some leaking around. So how does this thing, like these things we're talking about, happens? One, when there's a tube disconnection, or when patient has extubated. Sometimes the endotracheal tube could be there in situ, but patient might have extubated and you find the tip end part just lying within the throat, but not inside the trachea. So when that also happens, you should know that there is I mean something for you to check on. Okay, it will give you a low pressure alarm on the machine, in this case the ventilator. Then what else? When you have a tube disconnection, that one we've talked about it. Okay, so a tube disconnection, extubation, and when you have a cuff leak, yes. So endotracheal or tracheostomy cuff leak. So we have cuffs that you normally inflate. Okay, you normally inflate. It looks like that of a urethral catheter. You see, the one that we fill with sterile water when we pass the urethral catheter. Okay, just to hold it in place. So the endotracheal tube and even the tracheostomy tubes today have these cuffs around, but these ones we don't push in sterile water. Okay, it's just air that we use to inflate these pilot balloons or something like that. If you have any question at this time, you can let us know so that we help you.
What? I can't hear you.
Any question? If you have any question, you can put up your hand. Okay. All right. If no question, then I think we can continue. So this slide you have here summarizes everything for us when it comes to low pressure alarms and high pressure alarms. So you can look at my left-hand side here. Things that can give you a low pressure alarm. When you have circuit leaks, airway leaks, chest tube leaks, patient disconnection, plus all that we spoke about, they can give you a low pressure alarm. Okay. And things that can give you high pressure alarms, you have them here. Okay. So at a point in time when the patient coughs, the patient who has been intubated and on a mechanical ventilator, whenever this patient coughs, at that point in time, you will see the ventilator, giving you that high pressure alarm. Okay. And when the patient by the tube, like we talked about, when the patient is trying to fight the ventilator, what we mean by fighting the ventilator is, the tube inside the trachea itself, through the mouth, is not comfortable. That's not a natural way. Okay. And most of the times you put patients to, we sedate them, we paralyze them a bit, temporarily before we put in that tube. So whenever they wake up, they tend to fight the ventilator a lot, okay, because of the tube in there. Then things will be changed, like things will be changed as compared to the person's natural phenomenon of breathing. So most of the times patients fight ventilator until sedation and everything wears off and patient is well oriented. And even sometimes most patients do not cooperate, but I think with time, patients used to cooperate and they become calm on ventilator until they are ready to be weaned off. Okay, so when at a point in time when patient is trying to fight ventilator and even trying to extubate, like trying to pull the tube out and all of that, it generates some pressure in the airway, so that can also give you a high pressure alarm. When you have secretions of mucus in the airway, that can give you whether a tracheostomy tube or endotracheal tube. It can happen. Then airway problems, okay. Airway problems, we have, okay, so this is general. It can be any of what we talked about, okay. And when you have reduced lung compliance, this one could be related to maybe some few medical conditions, okay. I think like if you have COPD, for instance, or I think ARDS, okay, acute respiratory distress syndrome. When you have these conditions, what it means is that that's why you see most of these conditions we tend to get, especially with the ARDS, you need a form of high pressure, okay. What I mean by pressure is PEEPs. You need more PEEPs to be able to ventilate your lungs very well. So these two can give you a high pressure alarm. Then when you have water in the circuit, that's within the ventilator connections. Okay, when you have water in there, the water in there, I don't know whether if someone here is thinking about how water could get in there, it's more of a condensed water, okay, condensed water. So they can recollect within the tubes and will give you high pressure alarms. Look at, there are some things written red here. Never turn off alarms. Some alarms can be very, 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 should I say uncomfortable, right? But it is a taboo. It's a taboo for you to switch off an alarm just because you think it's making noise or it's too piercing to your ears. You don't do that. Okay. The alarms are there to protect the patient. They're not there to give you peace of mind. They are there to protect patients just in case something goes wrong. Now, the second aspect, you are saying assess the patient and not the alarm. So I think this thing has repeated itself. Whenever you find any of these things happening to a patient who is being ventilated, please, as soon as you go to the patient, check the patient first before you check the alarm or the ventilator. Any question at this point in time? If you have any question, you can please raise up your hand here so that we call you, okay? But if no question, then I think I have some few questions for you. Let me see. So let's look at this question. The first one, you are saying, what are strategies to prevent ventilator-associated pneumonia? I think this one is associated with in a previous lecture, though it's a continuation though. But let's try and answer it before we move on to the next one. What are strategies to prevent ventilator-associated pneumonia? If you want to answer, you can raise up your hand so that you can be unmuted. Anyone who wants to try? No one wants to try. Okay, Mr. Catherine, come in. You can unmute, okay?
Okay, please, I will choose
You will choose A.
and B.
A and B.
A and B. It says
Um,
that if it is only one, I will choose the A. But because it is SATA, I will choose A and B.
but you know, select all
Then,
that apply questions can either be one or all of them.
then A.
So you choose only one.
You've confused me.
Oh, but I just told you the truth. Or maybe I reminded you. Um, okay, so you choose only A. All right, thank you for your submission. Any
I will
other?
choose A and B. A and B. Thank you.
You now come back to add B. All right, thank you. Any other? Can we take another person? Let us try. Let us try. Who wants to try? All right, Laku, you can unmute.
Okay. I'm going for the B.
Yeah, you go for the C.
The B. The B.
B. Only the B.
Yeah, only the B. The with the option A. Oh, the screen is gone.
Yeah, just a minute. I'm coming. Okay.
So with the oral care, ideally you're supposed to do it every 2 hours, not 4 hours. So I will risk myself. I won't go for that. And then head of bed. Most of the time, it's advised you put patients, raise the head of bed to 30 degrees or 45. Unless it's contraindicated, just as the distance said. The option C, I will not go for it. You can't allow family members to sanction a patient. No. So I'll just go for the option B.
So you are choosing only option B.
Yeah, the B.
Very interesting. Can we get maybe one last person? Thank you for your submission, okay? One last person to help us. Have the courage to come out, okay? Okay, we have Sister Mary. Sister Mary, please, you can unmute. Sister Letitia, you can also unmute if only you are ready. Sister Mary.
Please,
Yeah.
hello. With the answers, the oral care, I know it's done every 2 hours. So saying 4 hours, yeah,
You said you
they
know
might
it's done
do
every
2 hours.
2 hours. Did you say every 2 hours?
Yes.
The rest of us, can we hear her?
Please, can you hear me? Hello.
Hi. Yes, we can hear you.
So, I
Yes, we
was
can.
saying that for the oral care, it's too early. And the head of the 10 to 15 is too low. So for me, I'll go for the 30 to 45 to prevent activation, so leading to the pneumonia. Then the option B, there is no way I can allow family to start treatment. Please explain again. Let me read this. The screen is off.
Sorry, I was taking off the network. So, Sister Mary, were you talking? Or Sister Letitia? I think Sister Letitia was talking, right? Or Sister Mary, if you are okay, you can let us hear you.
Okay, I will start from option D coming up.
Okay.
I'm saying that the procedure is not a simple procedure. You wouldn't even allow a UAP to do suction talk, less allow the family members to do. So that one is first out. Then the number C2, the bed position is not supposed to be 10 to 15 degrees. So that one too is out. Then the number B, I think that one, the degree of the bed is appropriate for a client with such kind of a condition. Then the number A, they said all those on this thing, the endotracheal intubation. It is good we do oral care to prevent a ventilator acquired pneumonia. Although we are supposed to do it 2 hourly, but if the 2 hourly is not applicable, I think 4 hourly wouldn't be too bad. So I will go for A and B. It's better than not doing the
Okay.
math.
Okay. So let's look at the answers now. The answers are A and B. So to those of us who were thinking of strictly 2 hours for oral care, it's a range, okay? It's 2 to 4 hours. All right, it's 2 to 4 hours. We go more with the 2 hours if patient has increased risk. Okay. But generally between 2 to 4 hours, it's fine. Okay. So let's take note. Let's take note of that. Then when you have head end of bed elevation, all right, either high foulness or semi-foulness, it helps to prevent the risk of this condition we're talking about. I think Sister Gloria has a question to ask. You can ask. Laku, is it an old hand or a new hand?
Sorry.
Okay.
Good
So,
evening.
Sister Gloria, let us hear you.
Good evening.
Good evening.
So please, I wanted to find out if you should meet 2 hours and then you should meet 4 hours. Which one should we go for?
It's unlikely, but should you meet between 2 and 4, please choose 2.
Okay.
For examination sake, if you meet 2 and 4, choose 2. But it's unlikely. Maybe after 2, you either meet 2, 6, and something else, or you either meet 2, 6, and maybe something else, or maybe 4, 6, and something else. It's unlikely for you to meet 2, 4, but should you meet 2, 4 with other options, please choose 2.
Okay, thank you very much.
You are welcome. Please, any other question? All right. So, Mr. Gloria, you can lower your hand. If there is no other question, let's look at this one too. So this one is more, I think it's more with what we were doing the last time. Okay, still not with pressure alarms. Let us look at this question anyway. A client has been intubated and placed on a volume cycled mechanical ventilator. The nurse carefully assesses the client for findings associated with a risk associated with this type of ventilator. But no problem. Let me take the question again. A client has been intubated and placed on a volume cycled mechanical ventilator. The nurse carefully assesses the client for findings associated with this type of ventilator. So what is this risk you are talking about? Who can try? Please, when you tell me your answer, you tell me what influences your answer. So wait, a quick one. Before we even look at this question, let me ask a follow-up question. When the last person also was addressing the point 4, when she was submitting an answer, she said something that, especially when I think she's relatives are not supposed to perform suction or so, and UAP cannot do that kind of, this kind of suction, right? So I wanted to ask, can LPN do sterile suction, like, endotracheal suctioning? Yeah, can they do? Can LPN suction an ET tube or a tracheostomy tube? Esther, you can unmute and talk to us.
Hello.
Yes, we can hear you.
Okay, so an LPN cannot suction a patient on ventilator, but rather I think that she can assist, because before you suction somebody on a ventilator, you need to give 100% oxygen before you start ventilating. At the end of the day, I also think that it's because it's an invasive procedure. An LPN cannot do that. I stand to be corrected anyway.
Okay, so fine, let that one be. Okay, let me hear from Mr. Mary first before I ask follow-up questions. Mr. Mary, I'll come to you, okay? I'll come back to you very soon. Mr. Mary, you can unmute. Sister Mary, oh, it's an old hand. Your hand is up.
Hello.
Please mute
Hello.
yourself. Yeah, okay.
Please,
You can
we
continue.
said those procedures that are more invasive and will need assessment before you carry out. LPN should not be allowed to do such kind of procedures. So I think this is a more technical and needs and need this in the activities of the RN. So for LPN, I would say no. I would say no. Because you need to, before you do suction, you have to what is it? Give oxygen and do other assessments before you can do, because the client is at more risk for a lot of complications. So it's not a client that you should delegate to a LPN. Thank you. But
Okay.
my answer is D, barotrauma. Because
Okay.
during the procedure, the first thing at hand is the barotrauma. The trauma, they can easily get trauma during the procedure. Before you can, hypoventilation will be after you have finished the procedure. You now assess to know whether it's okay or it's not. Then the hypercapnia too is the same thing. Respiratory, this one, the client will be at risk of alkalosis, because we say suctioning and vomiting, the client will end up being in alkalosis, not acidosis. So I think so. Thank you.
You are welcome. You are welcome. The rest of us, we are very quiet. What is happening? Okay. Okay. So when it comes to handling the airway, when it comes to handling the airway, you leave it for the RN or the critical care nurse. Okay. When it comes to the airway, you leave it to the RN to handle, especially those with an advanced airway. Okay. All right. So I think it makes sense. Lako, you want to talk? You can talk now. I want
I
to
just
say
want to
something.
ask, okay, so you said they can handle they are not supposed to handle the airway issues, right? So
Yeah.
I want to find out, how about the chest tube? Because I know they can handle some tubes like colostomy, chest tube or so.
Yes. So when it comes to care, okay, when it comes to caring for some of these tubes, they can care for it because they can, especially when it comes to the dressings and the rest, those are sterile procedures though, and they are allowed to perform. Okay. They are allowed to perform these care for sterile procedures and the rest.
All right.
Yeah.
Thank you.
All right. You're welcome. Any other? But you see, let me make something clear. Okay. LPNs cannot perform invasive procedures, but they can take care of some sterile procedures. For a UAP, it's a no-go area. When a question, let's say you get a question, and the question appears to be like a patient is not in distress. I mean, the question was very clear, telling you that patients had mucus in the endotracheal tube. Okay. And if there's any instance like it's only the UAP, sorry, the LPN who is around, please, the LPN can do suctioning. This kind of suctioning. Okay. Let's say if it's tracheostomy tube, that one is an advanced airway. They can perform such suctions. Okay. When the question makes it clear that it's mucus. So questions can be dicey. I want to tread carefully around these areas because the question can be in two different forms. When the question makes it clear that, let's say, the patient is in distress because of something, something, something. You see, when you find out that an assessment has to be made before the patient can be helped. If you sense anything like that in the question, no matter what, leave it to the RN. Okay. But if it's just for the purpose, for the purpose of maintaining an open airway, like the example I just gave, if the question just told you that maybe you are caring for a patient and patient coughs and produced maybe some thick mucus inside the tracheostomy tube, would you allow maybe the LPN to suction or something? They are qualified to do sterile procedures, but if it's for the purpose only to maintain patent airway, then they can do. So that's the exception. But if there is a hint that an assessment has to be made, the question did not give you like a direct question that an assessment has been made, like the one that I just gave. You see, this instance that I created, that patient's coughs and mucus is very visible, okay, or secretions are visible in the tube, LPNs can take it off. UAP is a no-go area because it's a sterile procedure. LPNs can, for the purpose of maintaining airway, tracheostomy tube suctioning, and this tube, the endotracheal tube suctioning we're talking about, for the purpose of maintaining airway, they can do some tracheal suctioning.
Oh, then say the answer should be yes. Or I'm not getting it right.
Yes, so it depends on the answer. So it's like yes or no. Okay. Yes, in the case of for the purpose of maintaining just an airway, like suctioning. You see, when I say it, I mean yes throughout. Even when you get maybe someone might be here, you get a question, and the question will demand that you perform an assessment before. Okay, let me see if I can get such a question for you. Let's say you are caring for a patient on a tracheostomy tube. Patient tends to cough repeatedly, okay, and produces lots of lots of mucus. Okay, and maybe now patient seems to be in distress and all of that. Okay. As soon as you sense any other thing that demands you to make an assessment or to make a serious intervention, please do not accept, do not give in to the LPN to go and care for this patient. So if only it is for the purpose of airway maintenance, LPNs can do. Any question on this one? Or it's still dicey? So let me give you an example. Let's say you have a patient with tracheostomy tube. You have a patient with tracheostomy tube, and patient starts coughing out mucus and the rest, okay? Visible mucus. Will you allow the LPN to suction or not? A question to all of us. Who can answer? For the purpose of airway maintenance, I think you can allow. UAP is a no-go area because LPNs can perform tracheostomy care, and if they are performing tracheostomy care and let's say there is visible mucus, they can't go and call the RN to come and suction for them to continue their care. Okay, that is why UAP can perform oral suctioning, because let's say when they are doing oral care, when they are performing oral care and at a point in time they have to suction or pull out some secretions in the mouth, they can do so UAP freely. Okay, so it's like that, but they can't handle any airway issue. as in a situation like a case, if there's any abnormality about it, they can't handle. I think the I've said the piece. I mean, everything is clear now. Right. All right. Let us carry on. So our answer to this one was what? Okay, so I even had a follow-up question. Can you LPNs pass NG tubes? Can they do that? Can an LPN pass an NG tube? No one wants to answer that. All right, let's carry on.
I'll go for Saima, let's answer, please. I'll go
So
for
what will
no.
you choose? No. So why
Yeah,
no?
it's invasive. They can only care for the tube, but the
Because
insertion.
fine. Because after that, it will require some assessment, even before, right?
Yes.
Yes. So they can't do that. That's not you wanted to say the same, eh?
Yes, please.
What about urethral catheters? Can they pass urethral catheters?
Urethral catheter.
Urethral catheters. Urethra. Can they do it?
It's a sterile procedure, but then it's also an invasive procedure.
Okay, it's also an invasive procedure, so they can't do it. All right,
Yeah.
thank you. Thank you. I think we should leave it here. There are other things I wanted to ask you about gastric tubes and the rest, but let's continue. When we are doing fundamentals, we shall look at that in detail. Okay. So someone chose barotrauma here, and I think that is the answer. So it is true. Okay. Esther Catherine, please, you can unmute yourself and talk to us.
Yes, please. Please, I wanted to know the difference between the invasive and the non-invasive, please.
Who can help us, sister? Difference between invasive and non-invasive.
Hello.
Yeah, let's go.
I think invasive procedures are procedures where you need to insert something to a place where you cannot see. You cannot use the visible eye to see. So it comes with experience. So if you don't have experience, you will not actually be able to perform those procedures. So that's why it's not delegated to the lower rank staffs, but to rather a senior or qualified staff. So let's see, IV line is an invasive procedure, NG tube, a urethral catheter, because you cannot actually see where it's going. It all comes with experience. So you don't want to risk allowing other people to do try and errors too, because the little mistake we make, the client is going to go into another complication. So I think passing something to hollow tubes and other places is an invasive procedure. Place where you can't see the end of what you are actually doing. They are all invasive procedures. Thank you.
Thank you very much. Sister Janet.
Yes, invasive procedures are procedures that you are likely to enter into the mucous membrane. So tubular organs where it has lining, or you are likely to break the skin.
Okay.
Those are the invasive conditions.
Okay. So the opposite is non-invasive, right? Please, the one who has the question, are you okay? Is the person here? All right. Okay, so I think we can continue now. Mr. Catherine, you asked the question, right?
Yes, please. I'm
are
very
you
much
okay?
okay now. Thank you very much.
All right. You're welcome. All right, so let's carry on. Let's look at another thing here. Should you have a patient with radial artery catheter placement? situations where we have lots of situations, or we have, lots of situations which can indicate or give us reasons for giving you a radial artery catheter. The common one, or let me say the most commonest one, is the for the one that you do this Allen's test. How do you even call it? For arterial blood pressure monitoring. Okay. Or when you are taking ABG samples. Okay. I think we have someone here who wants to ask a question. Mr. Millie, please, you can unmute and talk to us.
The question before this one, the volume cycle.
Okay.
Yeah, please, can you explain that one?
Okay, a client has been intubated and placed on volume cycled mechanical ventilator. The nurse carefully assess the client for findings associated with a risk. And it's asking us which type of risk is that? Or someone wants to answer. This time, do you want to answer?
I want the explanation for the volume cycled mechanical ventilator. That one.
Okay. Okay. This time, do you want to answer?
Yes, I want to try.
Okay, try.
My understanding is that, so the volume cycle means that the clinician is controlling the volumes of air that the patient is going to get. So the volumes means that you are going to control the expansion of the lung. So if the potential of causing a barotrauma, if you give too much volume than the lung can take in certain conditions, that is what it means.
Please, are you clear?
Myself well. So the volume cycle is that the clinician is controlling the amount of air that is going to be given to the patient with the ventilator.
Okay. I think you've done a greater part of the work. You've even done all. Let me touch on it small. Let me add something small to it. So Mr. Millie, what it means is that you see, like the example I was giving, if you decided to give a patient, let's say 450 mils per calculation, the patient weight, you find out that you are supposed to give 450 mils, and you end up giving more than 450 mils. It means it's estimated to be it's estimated to be more than what the patient can take. Okay, what the lung can take, the lungs, both of them. So when you give more than what the lungs can take, that is a potential risk factor, barotrauma. And it is more common when you are giving high pressures and high volumes. What I mean by pressure, you see, for a normal human being, as like you and I, as we are respiring right now, we have some pressures that we respire with. Okay, let me use PEEP as an example. We have a normal PEEP of 5 walking around. It's estimated to be 5. Okay, let's say, should you give a higher PEEP? So that's also one thing that is capable of causing barotrauma. Okay, higher PEEPs and higher volumes, they are capable of causing this barotrauma. The worst is when you do both all together. So there are some conditions we do one higher than the other lower, okay, and vice versa. So any of them is capable of causing barotrauma. It's like you are giving something which is more than what the lungs can take. So with the issue of the volume cycled mechanical ventilator, it's exactly as our sister explained, but how it can cause is the little that I have added. Please, are you okay? Or you're still not okay?
Okay, I'm okay.
Are you sure you're okay?
Yeah.
All right. Thank you very much. I think we can continue. So we're looking at how to maintain or care for a radial artery. Okay, a radial artery catheter. You know, we know where our radial artery is. Okay, on top of our radius, over there. So normally when we want to take samples for EBGs, or that's the most common place that some of our clinicians tend to put in their radial artery catheter, okay, for some invasive monitorings and also for maybe for samples for EBGs and the rest. Now, before you put in any radial artery, whether for the purpose of invasive monitoring or you want to pick a sample, okay, for investigations or something. Before you put in a radial artery catheter, you'll have to perform this Allen's test. It is something we treat when we are doing EBGs, okay? But I'll not talk about it in a deep way, but we know that Allen's test is just performed to know whether that particular artery, okay, or blood supply to the extremity is good enough. All right, so you're saying Allen's test is performed before cannulating radial artery and determines adequacy of the ulnar artery blood flow. Circulation to the extremity is monitored frequently. So if you do Allen's test and it fails, it means you can't use that and you can't touch the radial artery there, because what it means is that already there is an impaired, it is only through the arteries that body tissues get blood supply. So you did your Allen's test by blocking both the radial and ulnar arteries. And for a few seconds, you found out that a patient's arm was pale or something like whitish. After releasing the hand, it takes a very long time for patients' palms to resume its redness. Very long time. Then it means there's an issue with the radial supply, okay, over that part, and you can't use that. So you'll have to choose the other arm, okay. And even after it even passes, you have to monitor that extremity frequently. So you are saying you assess for color, capillary refill time, then the sensation, whether the person can feel on that hand, especially with the distal parts of it. You have to monitor for temperature. If there is inadequate blood supply to the extremity, especially to the distal end, temperatures will reduce because it's blood which supplies or distributes the warmth created within the body. It's the blood which supplies, which sprays, okay, the warmth. So if you have temperature reduction, extreme temperature reduction over there, it means the part is not receiving enough blood. Then you monitor for movement too. We are saying impairment in any of these parameters is reported immediately because it indicates impaired circulation to the extremity, and that should warrant for immediate removal of the catheter. To maintain patency of the arterial blood pressure monitoring system, an IV bag of normal saline is placed in a pressure infuser device to set. So this is like the setup we did, okay, for invasive monitoring when we were doing the phlebostatic axis. That diagram we displayed. Okay. So the pressure drops as the volume of solution in the bag decreases and can be pumped back up. All right, so what this slide is trying to tell us the most is that whenever you have an arterial line in situ, especially a radial one, try to do this assessment in the distal part of the hand, okay? If there's an issue with capillary fill time, the normal time shouldn't exceed what? 2 seconds. You assess for the color, the color you are searching for. You have to monitor for the sensation, temperature, and everything. If these things are not there, then you should call for help. Just inform your healthcare provider for it to be removed. All right. Any question on this one? So this one was a very quick one to note. Okay. And remember, when you do a lens test and it fails, you can't use that artery like we spoke about. Let's look at PEEP now. So positive end expiratory pressure. Okay. Positive end expiratory pressure management with acute, I think it's supposed to be ARDS, acute respiratory distress syndrome, ARDS. All right. I think I've said it in live class before. Okay, I'll not mention it now for the purpose of something. But people with ARDS are unlikely to breathe on their own. They always need a ventilator until the issue has been resolved. Just take note of it. And it doesn't even end there with just a normal ventilation or ventilatory support. They require higher PEEPs. Okay. So positive end expiratory pressure. Look at the name. Positive end expiratory pressure. So okay, let us look at what we have here. Then after I will explain in different terms. It applies a given pressure at the end of expiration. So just picture it exactly as you see here. When you are expiring, like you are breathing out, the pressure at the end of the breathe out process or at the end of your breathing out, okay, during mechanical ventilation is what we call the positive end expiratory pressure. Okay, so it's like when you are breathing out, there's a pressure which is, pushing, or which pushes the air out at the end part. Okay, and it is this kind of air pressure. It is this kind of air pressure that helps to keep the alveoli of the lungs opened and prevent them from collapsing. Let me try and draw something here to demonstrate something for you to see if maybe it will be okay. So let's say you have this to be one of your lungs, okay? You have your alveoli tissues. So let's say normally your alveoli should be like this, okay? Like should be like a ball. I'm just trying to make a demonstration, like a round thing like this. But because of this condition, ARDS, if you don't know much about ARDS, find out about ARDS. But in short, what I can tell you about what happens in ARDS is that they have difficulty in gaseous exchange because the lungs are collapsed. Gaseous exchange within the alveoli becomes very, very difficult because of the collapsed lungs. So this is a representation of how a normal alveoli looks like. I'm just trying to give you a nice demonstration here. But in a person with ARDS, let's say you have it this way. Okay, you see flattened or almost collapsed this way. Okay. So anything that comes in here, like let's say this is your trachea, so you breathe in here, okay? So let's say this is someone's head and someone's neck who breathes in, okay? So when the air enters your lungs, The alveoli is the basic unit of your, or the fundamental unit of your respiratory system. And it is within the alveoli of the lungs that gaseous exchange occurs. Now, you have an ineffective alveoli, or let's say ineffective alveoli, like all around. Okay, so whenever air comes in, you have the air in there, but for you to be able to, the blood brings deoxygenated blood to, okay, like carbon dioxide, in this case, to the lungs, for the carbon dioxide to be removed. But let's say if you have the alveoli collapse this way, the alveoli itself is not opened to take in the carbon dioxide coming from the blood and to cause the exchange, okay, to give the carbon dioxide out, then to take the oxygen coming in into the blood. It is the alveoli which is supposed to do that. And the alveoli are all collapsed. So in this case, what happens? We want to give a significantly high PEEP, okay? We want to give not too high though, but at a certain level, we want to give high PEEP so that, with the help of a mechanical ventilator, okay? So when we want to give high PEEP, it's by the mechanical ventilator. So we want to give high PEEP so that the lungs can, at least the high PEEP can open the lungs a bit for the gaseous exchange that should have occurred in normal alveoli to happen. So it's like when you are expiring, the pressure keeps your alveoli open a bit so that the carbon dioxide which is coming from the body or from the blood can diffuse, okay? The gaseous exchange can happen because it's only when the alveoli is open that the gaseous exchange can happen. So that the alveoli will pick up the CO2 and gives it up to the upper airway. Then the oxygen also coming down can enter into the same alveoli, then push it into the blood to enter into the left side of the heart to be pumped into systemic circulation. So that's what happens. Okay, so that's the PEEP we are talking about. So positive and expiratory pressure. So, so you see, we are saying it counteracts small airway collapse, okay, and keeps alveoli open for gaseous exchange or for gas exchange. And PEEP is kept at 5 centimeters of water. Okay, it's kept at, so this is like a normal standardized one for everybody, like I was telling you before. But let's continue with our note and see. However, a higher level of PEEP is effective treatment strategy for ARDS, a type of progressive respiratory failure causing damage to type 2 surfactant, surfactant producing pneumocytes, leading to atelectasis, the lung collapse we are talking about, non-compliant lungs, poor gas exchange, and refractory hypoxemia. Because all of these things will happen when your lungs are collapsed. So over here, we are saying high levels of PEEP. That's between 10 to 20 centimeters of water causes overdistension and rupture of the alveoli and barotrauma to the lungs. So air from ruptured alveoli escaped into pulmonary interstitial space or pleural space, causing pneumothorax and or subcutaneous emphysema. So look at what this one is saying and look at what this one is saying. If you want to treat ARDS, we want to keep the PEEP at a significantly higher one above this 5, okay? So some can even choose to do 8, some can choose to do 7, some can even choose to do 10, depending on the person's physiological needs. Okay, But over here, so you see, there's a strategy. I think critical care nurses here can even attest to that. So there's a strategy in giving these high PEEPs. Whenever you want to give this kind of high PEEPs, you would want to reduce the volume, okay, like tidal volume the patient is receiving. All our settings on the mechanical ventilator. So you remember I said it's pertaining to the question that I think one of our sisters asked, either milli or Catherine. I said when you are giving high PEEPs, then with high tidal volumes, you are likely to cause the barotrauma. Okay, you are likely to make it happen very quickly and faster, but strategically, higher PEEPs can be used to treat certain non-compliant lung conditions, okay, like ARDS. So that is all the idea behind this slide. If you have any question or addition, you can bring it out. And if you don't care for this patient well, and this patient happens to get barotrauma, you know, air will leak into tissues. It will penetrate through tissues around the lungs, and you're going to get this subcutaneous emphysema, air entering into subcutaneous tissues. All right, if no question, then let's carry on to the next one. So we are seeing hemodynamic effect of PEEP. Okay, so yes, there's something about PEEP. When you increase PEEP, remember that when you increase PEEP, you're also increasing intrathoracic pressure in a way. Okay, and intrathoracic pressure decreases venous returns and also decreases preload. Preload is the amount of blood present to be pumped into systemic circulation. That is one way to define it. Another way to is an amount of blood entering the heart. Okay, so whichever way you want to understand it, but that is preload. Okay, so when preload also decreases, cardiac output will certainly also decrease. And that will give you hypotension. So this lots of questions can come around here. When someone is receiving high PEEP, what is likely to happen is hypotension. So in the question, when they give you, let's say some parameters of low blood pressure, and they tell you that this patient is receiving high PEEPs of anything above, let's say 7 or 8, okay, going. Sometimes they like to even give you more, a significantly high amount of PEEP so that you know, if you know, you know. So that's how the case is going to be. If you know, you know. They are likely to give you 10 and above. Okay, 10 and above for someone whose blood pressures are already low. It means when you give high PEEPs, you rather cause more hypotension, or you make the hypotension worse. So high PEEP can risk you to hypotension. Take note, not hypertension. And we are also saying keeping alveoli open between breaths with PEEP improves gaseous exchange and decreases hypoxemia. We've talked about this. And it also allows the use of lower FiO2s and decrease oxygen toxicity. So that even allows you to decrease the amount of oxygen you want to give to patients at a particular time, because oxygen is a drug. When you give too much of it than what the patient needs, you cause oxygen toxicity, which also comes with its own issues. Any question on this one before we move on to the next one? But I hope we are all here. We are all paying attention, right? All right. Let's look at another thing here. So Sister Millie wants to ask a question. Let us hear you. You can unmute.
Yeah. So I just want to clarify with the respiratory distress one. So the normal PEEP they can have it's like 5, but for that condition they can give more than 5, but it shouldn't exceed that between 10 to 20, if I'm correct.
Yeah, so the 10 to 20 is likely to give you barotrauma. Some physicians can even go around 10 and the rest, but it all depends on the physiological needs of the patient. For examination's sake, PEEPs that are likely to cause barotrauma are from 10 to 20 or even more.
Okay.
Anything less than 10 is unlikely, okay? But the standard one is 5.
Okay.
All right. Any other question? Please, I think someone also raised their hand. You can unmute. I give you that permission, if that is okay with you. But if there is no other question, then I think we can continue. Now, let's look at some emergency criteria for activating rapid response team. This is also a very nice and good part of it thing for us to pay attention to. All right. So let's look at the first one. Okay, we are saying an acute change in any of the following calls for the need for activating what? A rapid response team. When you have a heart rate of 40, less than 40, you have to call for the rapid response team. Take note of these things. There are questions around plenty. Okay, remember, those of us who have had a chance to partake in the EKG class, we learned something about athletes and their, not all of them, but some of them, some athletes and their heart rate. Some can have a sustained heart rate of 50 or even 48, which can be their normal. Okay. And it calls for no harm or no, it calls for no intervention. But no matter what, whether the person is an athlete or not, anything below 40, at least call for the rapid response team. Okay. Then if you have heart rate of 130 or more per minute, call them. If you have a systolic blood pressure of less than 90, it also requires the need to call for rapid response team. Okay. Then a heart rate, respiratory rate of so I think this is the systolic, right? Systolic BP of less than this. I think diastolic 2 has its own range. Is it less than 40? I think so. When you have diastolic 2, I think it's less than 40 or so. You have to call for rapid response team. Then when you have respiratory rates of less than 8, you call more than 20. So this one, 8 inclusive, okay, with a respiratory rate 8 or less. So it's something, it's supposed to be 8 less than or equal to 8 here. This one too is supposed to be greater than or equal to 28. Okay. So they all call for rapid response team. All right. If you have a saturation, oxygen saturation percentage of less than 90, it's also despite oxygen. So let's say you are giving oxygen and still patient saturation remains less than 90. Please call for rapid response team. Okay. Call for rapid response team. All right. Any other question? If you're caring for a patient and for 4 hours, you find out that patient has given you less than 50 meals, 50 meals included. 4 hours, within 4 hours, you have to call for rapid response team for them to help. Then a low level of consciousness, okay? When you have level of consciousness to be low, you have to call for rapid response team. So that is it. If you have any question, you can ask. Is that Janet, you can unmute.
Yes, I see that the other parameters, we see the lower limits. Higher BP that you have to call the rapid response team.
Please, at a point I didn't hear you. Can you come again?
Yes.
Hello. The rest of you can hear me. Sister Jane, can you hear me?
Hello, yes, I can hear you.
Hey, please come again with what you were saying.
Yes, I was asking the BP.
The BP. The sound is on and off.
What is the level?
Which one? Which level?
I mean,
Hey, this thing is breaking. Can someone hear what she's saying? Or maybe it's from my end. Could you hear what she said? Did you hear what she said? Hello?
Hello.
Sister Jane. Can anyone hear me? Your line keeps breaking. I don't know whether it's from my end.
Yes, I can.
Okay. Please type, if you can type your question for me. I can't confirm whether it's from my end. Okay, someone says yours. Okay, so upper limit for BP. Are you asking for upper limit for BP?
Yes.
Okay, yeah. So I think I spoke about that. With the systolic blood pressure, we said if you have anything less than 90, you have to call for rapid response team. And I think with the higher one or the highest point, is it 180 or 160? I think it's 180, right? Anyone here to confirm? I think it's 180. 180. And I think 180 is even a hypertensive emergency. When you care for a patient, the patient comes to the hospital, we check the blood pressure, and the person has a blood pressure of 180. You can't allow the patient to go home. Even if the person came in, like as in walking, you can't allow this patient to go home. Okay, 180 and above is hypertensive emergency. So I think it's 180. Yeah. All right, any other question? All right, I think we can move on now if there are no questions. All right, let's look at another thing here. It's my prayer that we finish with this one before we all leave. Okay. Let's look at neurologic injury, people who who, okay, let me put it this way. After cardiac arrest, one complication that worries a lot is, I don't know whether most of us here can just relate. You can have a patient who was doing well at a point in time, and maybe the patient had an arrest. You will intervene, and at a point in time, you will get the patient back. But this patient will never be able to wake up. I mean, the person will have, how do we call it? Hypoxic brain injury. The person will tend to have hypoxic brain injury, which can cause a very devastating neural complication. And if care is not taken, this patient can even get brainstem reflexes all gone. Okay, so we are come to look at neurologic injuries in cardiac arrest, and we have something we call therapeutic hypothermia. It helps a lot, okay, for cerebral perfusion injuries, especially during cardiac arrest. That is what we are come to look at right now. So when we talk about therapeutic hypothermia, therapeutic means treatment, like something that helps in treatment. And hypothermia here is low temperature. So it means we are come to induce a low temperature for you in a way to treat you. That's what it means. Okay, so over here, we are only relating it to cardiac arrest. It can be related to other things, okay? But it's more common here during cardiac arrest, like the example I just gave. And I think most of us can relate. So neurologic, let's look at what we have here. Neurologic injury is the cause of mortality in cardiac arrest. Of course, that is true. Especially VFib, which is ventricular fibrillation, okay? Or pulseless ventricular tachycardia, or VTAC. So these are the only two shockable rhythms we have. Inducing therapeutic hypothermia within 6 hours of arrest. Let's take note. Inducing therapeutic hypothermia within 6 hours of arrest and maintaining it for 24 hours decreases mortality rate and improves neurologic incomes. Let's look at this one too after I'll talk about it in a bit. Indicated in all patients who are comatose or not following commands after resuscitation. The patient is cooled to about, if it's degree Fahrenheit, that is it. In degrees Celsius too, that is the equivalent. Remember on the NCLEX, whenever you are given temperatures to consider, if they give you in degree Fahrenheit, they may as well give you in degrees Celsius too. Okay. So you do that, you keep the patient cooled at this temperature for 24 hours before you rewarm the patient. Okay, before you rewarm the patient. So one thing is, after, for those of, some of us who are working in acute care settings, I think maybe we might have seen some before. After cardiac arrest, or even sometimes in severe neurologic conditions where we think it's applicable, we can do. So let's say a patient who had, let's say, a bit higher GCS ran into shock, or let's say any cardiac arrest. After resuscitation, after resuscitating this patient and we've gotten him or her back, GCS seems to be low. Okay. So within the first 6 hours, what this part is trying to tell us is that we have to keep the patient, if only it's indicated, therapeutic hypothermia, that's the name. We have to cool this patient throughout for the first 6 hours. Okay. Sorry, we have to start the therapy within the first 6 hours after the person has been revived. And the person should be sustained in this cool temperature for 24 hours. That is what we are saying. So the time for you to start is within 6 hours. And for you to maintain the temperature below 34 and not below 32 should continue for 24 hours. Then after the 24 hours, you start warming patients small. Okay. And we are saying cooling is accomplished by cooling blanket, ice placed in the groin, axilla, and sides of the neck. And we even cool their IV fluids too. Okay. We refrigerate, we cool it with a refrigerator or any means that you can use to cool IV fluids. We want to keep them cool. Okay, cold. So we use all of these plus cold IV fluids. Then and please, they can't undergo this therapy without being connected to the cardiac monitor. And that's why, of course, these treatments are given in the ICUs. Okay. So this patient has to be closely assessed on the cardiac monitor for signs of bradycardia. You know that when a person is cooled, the vagus nerve, okay, or there could be vagal nerve stimulation, which can decrease heart rate. Take note of that. When someone is super cold, vagal nerve stimulation can happen, especially putting this cooling blanket and the rest at the sides of the neck. You have the vagus nerve around the neck innervating your chest, okay, and that side, so they can be stimulated. And when the vagus nerve, I think cranial nerve 10, right, when it's stimulated, you can have low heart rate. So that's why we are mentioning bradycardia here, which is more common in people like that. Then BP2 with the mean arterial pressure. Mean arterial pressure is obtained from blood pressures. We want to keep the mean arterial pressures at above 80 millimeters of mercury. And we have to assess skin. Okay. We have to assess skin for thermal injury. Apply neuroprotective strategies. That's head, end of bed. For neurologic conditions, we even want to give them elevation of 30 degrees. Okay. So you're saying after 24 hours, patient is slowly rewarmed. So look at it. After the first 24 hours is up, we now rewarm patient slowly. It's very important. So that is therapeutic hypothermia for us in real life cases and for examination's sake. Any question here at this time? Before we look at another thing, ask your questions. So I think we have someone here. Nana, please, you can unmute and talk to us.
Okay. Please, it appears I didn't get the second bulletin right as to the indication for the cooling. Can you stress on it a little bit?
Okay.
Yeah.
It said, do you mean this one? Cooling is accomplished by, or this one indicated in all patients who are comatose? Which one? The cooling. Is it the cooling? Okay. So if I heard you, I think it's the cooling. So cooling is accomplished by cooling blankets. Okay. So we give them cooling blankets and we put ice. Okay, Nana. You can unmute and talk to us. Is it the cooling one?
No, I mean the indicated in all
Indicated,
patients
okay.
who, yeah,
Okay.
comatose, yeah.
Okay, so what you are seeing is that therapeutic hypothermia is indicated for people who are comatose, okay, or not following commands after you've done resuscitation attempts, okay. So let's say with patient has had a cardiac arrest, this patient's GCS was a bit higher. Right after arrest, the patient is not even able to open the eyes. GCS is low now. Okay, let's say the patient had an initial GCS of, let's say, 8. Now, patient after arrest, patient GCS is about 4 or 5. It means GCS is low. Okay, most of the times around 5, thereabouts, or even less, patient's eyes will be closed or almost comatose. Okay, so when this happens, it means within the first 6 hours from that resuscitation attempt, we can do this therapeutic hypothermia induction for the person. Okay, and so that's what we mean by it's indicated for all patients who are comatose or not following commands after the person those people have had cardiac arrest and they've been resuscitated. Okay, we've resuscitated them and they are now back, but they are comatose. Their GCS has not improved. So we can do this cooling for them, and the temperature range is what we have here. We keep them within these low temperatures between 32 to 34 degrees Celsius for 24 hours before we start rewarming them. And the third bulletin is how we keep them cooled. So that's what we have here in the third bulletin. Please, Nana, are you okay now? Or you are still not clear? You are okay. All right. Any other? Okay. So let's look at this one. Malignant hyperthermia. When we talk about malignant hyperthermia, who can tell us we have another condition that looks very, very similar to malignant hyperthermia? Who can help us with that? Have we forgotten? Okay. Let's talk about our malignant hyperthermia. Okay. After maybe we shall look at that. So it is a life-threatening inherited muscle abnormality. After this one, I think I'll try and drop the difference, okay, between malignant hyperthermia and I also want to mention the other one. I'll try and drop the difference on the page for us to get to know. Okay, so it's a life-threatening inherited muscle abnormality triggered by drugs used to induce general anesthesia. Okay. The triggering agent Okay, sorry, I think my network took me off. Please, can you see my screen now? Okay. So I was talking about malignant hyperthermia. I think we reached here. The triggering agent leads to release of calcium from muscles, okay, leading to sustained muscle contraction and rigidity. It can occur in the operating room or within the PACU. I want to give you, I'm coming. Have you heard of neuroleptic malignant syndrome before? NMS? Anyone here? So that is what I wanted to ask, and no one was saying anything. Okay. So let us continue after we talk about it. The triggering agent leads to release of calcium from muscles, leading to sustained muscle contraction and rigidity. So it occurs in the operating room or post anesthesia care unit. So that's the PACU. Specific characteristic signs and symptoms of malignant hyperthermia include hypercapnia, okay, which is the earliest sign. Then you tend to have generalized muscle rigidity. So you see jaw clenched, okay, everything will be very rigid. The trunk, extremities, and everything will be very, very rigid. And there will be extremely high temperature, hyperthermia. Okay, there will be extremely high temperature. So the hyperthermia is a later sign that will let you know. After, when there's a continuous contraction, some heat is generated. So the accumulated heat after time, I think it's one way of causing that extreme high temperature. Okay, so when the hyperthermia comes in later, then I think it confirms it's more of the malignant hyperthermia. Then what we are saying is that you monitor temperature as it rises 1 degree Celsius every 5 minutes. Okay, exceeding 40.6 degrees Celsius. And you notify healthcare provider indicating immediate treatment. The main treatment which is used, it is very common. This drug, I think it's even used in the management of the other condition we talked about, the neuroleptic malignant syndrome, dantrolene. So if you are about to write your exam, there are some things, whether you meet them or not, it's like someone will always say, know what everybody knows. Okay. Every NCLEX student knows about dantrolene, so you should also know about dantrolene. Okay, Lako, thank you, hands up. You can talk to us.
Yeah, please, I just wanted to bring a side. Can you please be reading the comment section? Some of us are not able to talk, so if you can read the comment section to help us.
I want you to talk. Okay. Okay, I want you to talk. So raise up your hand and talk. Otherwise, you will be slowed. Okay, so someone was talking about Kawasaki. Not Kawasaki. Okay, rhabdo is it myelus or meiosis? Myelus, yeah. Rhabdomyolysis. That one too, yes, you have extremely high temperature, but it's also a bit different, okay? So I think it's NMS that I wanted to talk about, neuroleptic malignant syndrome. So next time, raise up your hand and talk to us, okay? My seniors. Okay. All right, thank you. Anyway. Okay, so let me see. Yes, so dantrolene, like I was saying, okay. Other signs of malignant hyperthermia you can get, apart from the hyper, please, if you don't see, what is this thing? If you don't see hypercapnia and you see hypercarbia, are you still correct or wrong? It's still correct. So take note of the words, hypercarbia. When you see that one too, okay, basically the same thing we're talking about. Muscle rigidity is there, okay? So everything will be, if they're on a ventilator, it will be very difficult for you to ventilate them, because it's like, because there is continuous muscle contraction, their peaks, like peak pressures will go up and very, very high. Okay. So let's take note about that one. And okay, because there is continuous muscle breakdown, especially calcium release. Calcium release into the blood. Hypercalcemia is possible when you have lots of calcium in your blood. If care is not taken and you have all this muscle breakdown, you are likely to even have renal failure. Okay. You are likely to have renal failure. So you can relate, okay? If you know what is happening on NCLEX, sometimes you will not get exactly as you read, but if you understand the whole concept of what you yourself you've read, you can relate lots of things, okay? Right now, you've heard of dantrolene. It's similar in treating neuroleptic malignant syndrome. Like I said, after class, I'll try and drop something between the different. All right. So if you have any question, you can ask. If you have any question, Mr. Janet, you can talk to us. Mr. Jamie, can you hear you? Can you hear us?
Hello.
Hello. Hey. I think it's network. All right. I don't know, please, you can type it for us, okay?
Hello.
I'm sure the rest of you can hear me, right? Mr. Jane, your network today. So, should you get question on malignant hyperthermia? Let's say case study questions. Some of the labs that you're supposed to check, lab investigations. Electrolyte is sorry, sorry. Electrolyte is very important. You know that because of the high calcium release into the blood, electrolyte is very important. Then myoglobin, you have muscle breakdown. Myoglobin is also there. You have to check for lactate, okay, lactic acid production. So lactate is also very important. Then urine analysis, like urine myoglobin is also there. You have to check for that. All right. What else can we see about treatment of malignant hyperthermia? So you have to cool them, okay? You have to keep, we want to keep temperatures between 36 to 38 degrees Celsius. So you lower the room temperatures, you apply ice packs around, okay, the patient's body. Then if you get an option like lavage body orifices, okay, it should be parts. Okay, lavage open body cavities. example, I think example like if the person has an NG tube, you can do maybe lavage. It will one way help to lower the temperatures more. Then you can do bladder lavage and the rest. I think it's okay for now. Don't forget dantrolene. Whatever happens, don't forget dantrolene, the treatment of malignant hyperthermia. Dr. Rosemary, please, you can unmute and talk to us.
Hello.
Yes, we can hear you.
Please, you mentioned bladder lavage, and I don't know how that will reduce the temperatures. I just don't understand it.
Okay, so bladder lavage, gastric lavage, and the rest. You know, when you push in cold water and you bring them out, in one way or the other, it cools you.
Mm.
Yeah, it cools you. It's like it picks it picks some of the warmth in there. Okay, then it brings it out. So it's one way of cooling your body.
Oh, okay.
Some even do rectal too in addition.
Okay.
Yeah, so
So with this, most of the times are patients unconscious with this condition, or they are conscious?
oh, they are conscious. So let's say someone
So
can
if they
go,
are conscious, then it means oral fluids, which are also cold, can be allowed. Or
oh yeah, like you can think of anything that can help to cool patients. Anything. Okay.
okay.
Anything that you can do for which is not contraindicated in the patient situation and you can do to help cool patients, it's fine.
Hmm.
Yes. Okay. Let's look at another thing here. Let's see what we have here. I want us to finish this one quick before our time is up. Let's look at COPD. People in BiPAP using BiPAP mask or BiPAP to treat them. My assignment to all of us, let's
Sir,
find out the
please,
difference.
I want to take a screenshot of the previous slide, just ended one. I beg you.
Hey, madam.
I beg.
This one.
No.
Hey, is it this
Yes.
one?
Yes.
So are you taking screenshots of everything?
No.
Ah,
I just want to highlight something that is why.
something that, yes. So
Thank
and find out more. Okay.
Thank you.
You're welcome. Thank you too. Let us find out about difference between CPAP and BiPAP. Okay. If you are here, you don't find that out, you are going to meet it on your own case. So go and find out. Okay. All right. So there is bi-level positive airway pressure. CPAP is continuous positive airway pressure. And exacerbation of COPD is characterized by acute worsening of baseline symptoms. That's dyspnea, cough, sputum color change, and production. Non-invasive positive pressure ventilation, that's the meaning of this. Non-invasive positive pressure ventilation is prescribed short-term to support gas exchange in moderate to severe COPD exacerbations and acidosis, okay, or hypercapnia. NIPPV, that's non-invasive positive pressure ventilation, can prevent the need for tracheal intubation and it's administered until the underlying cause of the ventilatory failure is reversed with pharmacologic therapy, like the use of steroids and bronchodilators and antibiotics. Let me show you something here. Okay, so let's finish with this one after I'll show you something. BiPAP involves mechanical device, a face mask, in conscious patients breathing spontaneously. We are saying BiPAP delivers oxygen to lungs and removes carbon dioxide. Carbon dioxide retention causes mental status change. If patient becomes drowsy and confused, it's likely that the patient has retained more CO2, especially when you put someone on BiPAP max ventilation, and at a point in time, you see that the patient is becoming more drowsy. It means the patient is retaining more CO2. And, you know, when you have more CO2 in the blood, you know what will happen. It has this tendency of causing this poor mental status change, right? If patient is drowsy or confused, it's likely that CO2 is retained, and BiPAP mask should be removed. And you remove before you report to healthcare provider. Okay. Arterial blood gases evaluation is obtained to determine carbon dioxide level and BiPAP effectiveness. Altered mental status poses threat to survival as it leads to decreased protective reflexes, like the patient, when someone has low level of consciousness, the person cannot, swallowing and gag reflexes will be very slurred. Cough reflex will be very slurred. It will get to a point in time where the patient cannot even breathe well. And for that matter, invasive ventilation will have to be given. Let me show you something here so that you appreciate what we are talking about right now. Let me see. BiPAP mode ventilation. Look at the images here. So have you seen how it is? You have a normal ventilator, okay? And we have BiPAP, mini machines over there too that people normally use at home. So you can see this one. This is a small BiPAP machine. We have small ones there, but even with a normal ventilator can also do BiPAP ventilation and CPAP. So what we spoke about, let me pick my pen here. So we said non-invasive, positive pressure ventilation. So non-invasive, this reminds me of the question our sister asked, if we remember, the difference between invasive and non-invasive. I think if you are still here, you can appreciate it, right? So you see, we didn't insert or we didn't put any ET tube into the trachea as an invasive way to help the breathing of these patients. We are doing non-invasive positive pressure ventilation. So this is a BiPAP mask, okay, with a seal, a tight seal. Then this ventilator is connected to an oxygen source and settings made appropriately. We'll be delivering high pressure. So like I said, BiPAP, I give this as an assignment, but anyway, let me just mention it. BiPAP mask, bi-level positive airway pressure. So this one is like, it's, positive pressure is more like it delivers air with pressure into the lungs, okay? And because this one is like a bi pressure, okay, like bi-level positive airway pressure. It sends it in, then it breaks it out to all under pressure, okay? So two-way level. Okay, it pushes the air in under pressure, brings it out under pressure. So that's BiPAP. The CPAP is continuous positive airway pressure. So it gives only one way. Okay, pushes the pressure in there alone. It doesn't do that bi-level or, in and out cycle. Okay. So that is it. They are all non-invasive ventilation modes. Okay. All right. So I think you can now appreciate it. All right. So we are saying that when a person becomes drowsy on that diagram I showed you, the picture I showed you, it means it could be that the patient is retaining more CO2 in the max. Okay. And that is making the patient drowsy. So you do your EBGs. If you think CO2 is too much in the blood, then you have to consider a different means. You have to remove the BiPAP mask or stop the BiPAP ventilation. Then you will have to do proper intubation and an invasive mechanical ventilation. All right, if no question, let's talk about basilar skull fracture in a bit. Okay, we just want to hit on some key points here and go. So basilar skull fracture, look at the name. When you have the base, so some call it base of skull fracture, it is the same thing. Okay, basilar skull fracture or base of skull fracture. So whenever you have any suspected head injury involving basilar skull fractures, when you have rhinorrhea, okay, or a clear fluid draining from the nose or from the ears, which is otorrhea, okay, that can be a cerebrospinal fluid leaking, okay. If there is a confirmed skull fracture and you have these things leaking from either the ears or the nose, it could be CSF leaking. You are saying if drainage is clear, dextrose testing determines if it is really cerebrospinal fluid or cerebrospinal fluid is in there. You do dextrose testing, please. It is not our normal glucometer that you're going to use to check. We have a special one for it. I'm sure. Okay, I'm sure there will be a special device. I don't know whether it's, but I don't think it is a normal glucometer. All right. We are saying the presence of blood makes, so let's say if you have this drainage and there is blood which has been tainted in it. Okay, you have this clear fluid with tainted blood. You are saying it makes the test unreliable as blood also contains what? Glucose. Okay, so when that happens, when you have, so you see every line here is trying to give you a point. One, we are saying if you have any skull fracture, like head injury with a suspected skull fracture, and you have some drainage within the nose, coming from the nose or the ears, and it's a clear one, you first of all do your dextrose testing of it to confirm whether it is cerebrospinal fluid, because it could be. The second point you are saying here is that, the second point you are saying here is that sometimes you can have blood mixed, okay, with these clear drainage. And if blood is mixed, now you perform this test. You will not perform the glucose test again. You will perform the halo or the ring test, okay, which is performed by adding a few drops of blood-tinged fluid to gauze. So the fluid which is leaking out, you add few drops onto a gauze. Then you assess the characteristic pattern of coagulated blood surrounded by the cerebrospinal fluid. So identification of this indicates that there is cerebrospinal fluid leakage and risk of infection. Okay. And when this happens, the nose is not packed. Don't pack the nose. Don't insert any NG tube or orogastric tube, because you might end up entering or penetrating the fractured scar. You don't know where. So you might end up putting the NG tube within the scar. That's the reason. Just imagine NG tube inside the scar. And we are saying these tubes are only placed under fluoroscopic guidance. Okay, so NG tubes are contraindicated. Orogastric tubes are even alright, or are even contraindicated. If any of these tubes should be put in there, it should only be under the guide of what? Fluoroscope. Under the guidance of fluoroscope. Then we are saying a bruise is suspected after a direct trauma, but okay, so we have two main signs. Should I say two commonest signs? I think most of us have heard of battle sign before. When you have bruising behind the ears, we call it what? Battle sign. It is one of the key signs of what? Basal skull fracture. Battle sign. And the other one is what? Ecchymosis, or bruising around the periorbital area, or periorbital ecchymosis or bleed. Okay, and the term for that one too is called raccoon eyes. Okay, so I don't know whether in a picture or a diagram, this is how you see it. Raccoon eyes. Look at how raccoon eyes is. So you see these patients with bleeding around the periorbital area. You see raccoon eyes. So the eyes looks like a raccoon, that bird. I think raccoon is a bird, right? So that is it. Okay, look at battle sign. Look at battle sign. So you see bruising just behind the ear. Okay, so this one too is battle sign. So that should also tell you that there could be a risk of what? You see, it can be nicely, bruised here like this. So that should tell you it is, there could be a sign of what? Basal skull fracture. So you are saying headache, when someone has headache, you can't, after a trauma, you can't, even malaria, common malaria, you get headache. Just stress can even give you headache. So you can't choose headache as a more clinical sign to basal skull fractures or something. Okay. Well, that is what you are trying to say here. Any question or addition? Any question or addition? I think at this point I've talked plenty, but if no one has any question or suggestion, let's look at this question. Who can help us? We are saying the emergency department nurse is caring for Mr. Basilar. Mr. Basilar, you can unmute and talk to us.
Okay, good evening, sir. Please, my question is on the malignant hyperthermia. I mean,
Mhm.
there's a point that says that I don't understand the sentence. That's it. Says
Mhm.
hypothermia expected immediate post-op. I don't know with the treatment. I don't understand it. That's all. So if you can
Come.
kindly go back.
Hey, we've passed by even long time.
Yes, yes.
You're now asking. What, which one?
Forward. No, the next slide. The next slide. Yes, hypothermia expected immediate post-op. I don't understand that sentence.
Oh, okay, okay,
This.
okay. So I'm coming. So what you are saying is that whenever you see these anesthesia drugs, they are likely to cause hypotension and hypothermia. Okay,
Okay.
because they end up dilating, causing vasodilation or dilating blood vessels.
Okay.
So whenever you have a low blood pressure and a low temperature, immediately from the theater room, we know you are, I mean, it's not a concern. But when the blood pressures become low, it's like sustained, like the low pressures become sustained.
Mm-hmm.
That is where the issue, I mean, that's why you should think of something happening. Okay. So let's say
Okay.
right after theater, you know, the person's blood pressure baseline before was maybe around 120 thereabouts. And the systolic was around, sorry, diastolic was around 70, 60 something. You come and patients, let's say blood pressures are around 90, 50 something.
Mm-hmm.
Around 90, 50 something, you should still have a mean arterial pressure of even 60 and above. I know the ideal one is 65 and above, but around that figure, even with 90, 60 something or 50 something, you should have if you calculate the mean arterial pressure, you're likely to even have 65 and above. So though it's a bit low, but it's a cause for no concern because we know it's a general anesthesia complication, like a side effect, not even a complication. But if let's say it keeps dropping, you know, things keeps dropping, then it becomes an issue. And mostly they recover within short time after post-op care. So it is the drugs that cause the vasodilation and cause all of these things. Okay. Please, are you okay? The one who has the question. Okay, okay. All right. Now my question. Let me see. Hey, some people's hands. Okay. So it's the person you're okay. Is that thing that your hand is up? You can unmute and talk
Yes.
to us.
Thank you.
Yeah, welcome. Tatina, let's go. Tatina, I can't hear you. You are unmuted anyway. All right. Let's continue with this one. When you come, okay, then you can ask your question. The ED, I mean, the emergency department nurse is caring for a patient who has been brought in by ambulance after sustaining a fall at home. What physical assessment finding is suggestive of a basal skull fracture? Who wants to try? Hey, Mr. Rachel is right on the screen. Who wants to try? Let me see my participants here. Mr. Catherine, you can talk.
Please, I would choose C, bruising over the mastoid. I think it's talking about the battle sign.
Are you sure?
Mastoid.
Yes.
I'm just asking. I'm not saying you're correct or wrong. I'm just asking. Are you sure?
Please, yes.
Some people don't like "are you
Because
sure"
it's not
question.
periorbital edema. You said ecchymosis around the eyes. You didn't say edema. So for the B, if I should have seen some blood, probably ecchymosis or
Oh,
something. Oh, thank God.
continue. Continue. I'm enjoying your rationale. Okay,
You
Sarama.
said
Thank you, Mr.
periorbital.
Catherine. Mr. Catherine, thank you. You've done well. You've done well. Sarama, you can unmute and talk to us.
I wanted to say C, but I've already seen the answer.
Okay. So let us read the rationale
Yeah.
quickly. Let's move on to the next one. The next is caring for a patient with increased intracranial pressure caused by a traumatic brain injury. Which of the following clinical manifestations would suggest that the patient may be experiencing increased brain compression causing brainstem damage? Please give me about 10 more minutes, okay? Because we had issues with network and the rest, technical issues. If only you can stay, please stay just only 10 minutes. Then after we call it off. Mr. Christie, you can talk, unmute and talk to us.
Okay. Please, sorry for taking you back, okay?
You want to take us back? Okay.
And please, about the PEEP.
But wait, let us answer this question first before you take us back. Okay.
Okay.
So what will be your answer?
Okay, the nurse is caring for a patient with increased ICP caused by a traumatic brain injury. Which of the following clinical manifestation would suggest that the patient may be experiencing increased brain compression, causing brainstem damage? I'll go for C.
Why?
Well, see, let me rock my brains. Okay, I know the answer is C,
Okay. But what was your question? Let me know.
The question I wanted to ask.
Yeah.
Okay, about the PEEP.
Uh-huh.
I didn't get it. So, what I got was, so a patient with that AR, acute
ARDS.
respiratory distress, that condition. So, those patients, if they have high PEEP, it's
No,
expected sign.
I'm not saying they have high PEEP. Their lungs are collapsed. If they have high PEEPs, then it means their lungs will not be collapsed. In the course of treating them, we give them significantly high PEEPs so that we can open their alveoli for gaseous exchange to occur within the alveoli. Okay. Hello, are you still there? I want to know whether you get it or not. So I want feedback. Are you there? Can you raise up your hand again so that I see you? So, so you can talk now.
And please, can you come again on that? Because I'm as if I'm confusing myself.
Okay, maybe you have something already in mind. That is why you're confusing yourself. Let me know what you're thinking.
I know that those people with that condition, no matter the amount of oxygen you give to them, they will still be their SpO2 will still be low.
Good.
So,
you are correct. Let me break you there before you even continue. Don't mute. So that is normal oxygen. If you give them 200%, 500%, if only there is something like that, give them 500% oxygen, they will still be in distress. Okay, so that is oxygen. Over here, we are talking about positive end expiratory pressure you can only use mechanical ventilator to do that.
Okay.
So
Okay.
it is the ventilator which is giving the pressures, not oxygen. Oxygen alone is like normal air. So we are talking about mechanical ventilator, the picture I showed you earlier. Okay, giving that pressure in there. So ARDS patient, if you get someone with a severe ARDS, the only thing that can save the patient and give you time is only intubation. Then you connect patient to a mechanical ventilator with significantly high PEEPs.
Oh, okay. So high PEEPs. I remember you said the normal value is 5. So when it's 10 to 20, it's expected. Or
So 10 to 20 is the range that is likely to cause barotrauma. So I said, depending on the patient, how well the patient is doing and physiological needs, we balance it with the tidal volume the patient is receiving, the amount of air you want to deliver into the patient's lungs. So over here, our target is not the air that we want to send in someone with ARDS, because the lungs are collapsed. No matter the amount of air you send in, nothing good will happen. So in this case, what do you want to do to help the patient? Let us increase the PEEP, okay? Remember, we are saying the PEEP will help the alveoli to open up. So in this case, we will increase the PEEP small, then decrease the amount of air entering the lungs, so that the little amount of air that enters the lung can engage itself in the gaseous exchange. Then you can help patients achieve normal breathing, a bit. But when you give patients high tidal volumes, when I say, I don't know whether the terms are becoming bigger, plenty in people's mind. Tidal volumes, like I said, the amount of air you set to enter the patient's lungs. When you give a high amount of tidal volume, and you're also delivering these higher PEEPs, it's like you have higher of these two things, and even any of them is capable of causing barotrauma. So when you give higher PEEPs and high volumes, you are compounding like pressures from two different sides into the lungs, and you are likely to cause barotrauma. So with this one, you increase PEEP a bit, then you decrease tidal volume, so that you have your PEEP that you want to open up the alveoli, you have it functioning in there, and you can have a small amount of air going into the patient's lungs.
okay.
Please, do you understand the concept?
Yes, please. I get it now.
Okay.
Thank you.
You're welcome. All right. Who wants to answer the question for us? This one. Oh, we are tired. Are you tired? I know someone will ask. Okay. Is the person like can unmute?
Okay, hello sir. Please,
Yeah, I can hear you.
I'll take bradypnea. Bradypnea. Because damage to the brainstem causes some issues with your respiration. So I think if there's like an intracranial pressure, there will be bradypnea.
Okay.
Mm,
Are you sure? Okay. Let us look at the answer. Surprisingly, it is shocking. Let us read the rationale. Let us read the rationale. Look at the question again. That is caring for a patient with increased intracranial pressure caused by a traumatic brain injury. Which of the following clinical manifestations would suggest that the patient may be experiencing increased brain compression caused by brainstem? Yes, causing brainstem damage. So look at the rationale. So it is the opposite of what you were saying there when you have brain stem compression. I think I was left with some few more things to add, but because of our time, let us end it here, okay? Let us end it here. At appropriate time, maybe next week, we shall use few minutes of our time to hit on the few things left. Because it's also very important. Then we pick it up from there. Okay. All right. If you have any question at this point, you can ask.